and we're joined by Dr. Mary Foote and Dr. Suzanne Algendi to give that presentation. Our second presentation will be on multi-symptom inflammatory syndrome in children, updates and case reports, and that presentation will begin at 2:45. From the health department, we have Dr. Julia Schillinger, and we are also joined by colleagues from the Columbia University Medical Center, Dr. Philip Zachariah and Dr. Eva Chung. With that, I will pass it over to Dr. Foote.
Okay, thank you so much, Allison, and good afternoon, everyone. It's nice to be back with you all. So today, at least for the first 45 minutes, we're going to be talking about first, where are we now, giving you some surveillance updates for New York City area, and talking about how now that mitigation is working, what are we doing next? And then we're going to have a nice special presentation on multi-system inflammatory syndrome in children, and we'll have a little bit of time, hopefully, for some questions and discussion. So as always, we have to start out saying this data presented today is our understanding of COVID-19 as of May 14th at 5 p.m. So yesterday at 5 p.m. So looking at where are we now, COVID-19 continues worldwide. Suppression has been achieved in some areas, but the outbreak, unfortunately, has been accelerating in other areas, especially more in the Southern Hemisphere. Since the first confirmed case of COVID-19 in New York City, we've had over 20,000 deaths attributed to the disease. And following a peak that we had in early to mid-April, our daily case counts, hospitalizations, and deaths have been steadily declining. So this suggests, on the bright side, that mitigation measures, including physical distancing, are working. And these measures, it's really important to emphasize that these measures must be maintained as we are preparing to transition to suppression measures. So taking a look, this map is from the Johns Hopkins Center. And as of now, worldwide, we've had over 4,400,000 cases of COVID-19. With over 300,000 deaths. And this map is looking at data from New York Times, showing that in the US, we've had over 1.3 million cases, which accounts for a third of confirmed global cases. And we've had over 84,000 deaths, which is about a quarter of reported global deaths. So where are we right now in New York City? So we currently have clocked in at over 186,000 cases with over 49,000 hospitalizations. And we've had over 15,000 confirmed deaths in addition to 5,000 probable deaths. And the probable deaths, we've been collecting data from at-home death reports and other sources to come up with these numbers. So this slide provides information on how the epidemic has been evolving in New York City over time. So these data reflect information from the start of the pandemic in March 3rd to 5/12, so May 12th. So the top figure shows case counts by the date of diagnosis, and the middle figure shows hospitalizations by date of admission. And finally, at the bottom, it's showing that deaths according to the date of death. And just as a reminder, you'll see the deaths curve lags behind by 1 or 2 weeks. And that is due to, of course, when somebody is hospitalized, oftentimes they may survive for a week or two before, unfortunately, decompensating. So looking at COVID-19 rates by borough in New York City. And so this is looking at rates. So number of positive cases per 100,000 people in each borough. And then on the right, we're looking at the total cumulative count of cases in the respective boroughs. So looking at by the rate, the Bronx has actually been the most highly impacted with almost 3,000 cases per 100,000 people. And Staten Island, of course, has been very heavily impacted as well. Queens, who had, of note, has had the highest count or cumulative number of cases at almost 60,000 cases. And that accounts for the total of 186,000. And so we just wanted to give you updates on where we are in terms of the New York City developed milestones. And these are things that we're looking at to show how the outbreak has been progressing and hopefully help us make better informed decisions about reopening. And this slide shows the metric of people admitted to New York City hospitals. So this is all New York City hospitals that we have data for. And so we want to be below that dotted line for more than 10 consecutive days, which we have achieved this, which is very encouraging for us. And so looking at that set point that we have of 200, that would be double the average for prior years in New York City for the same time frame. And this figure shows another milestone, which is the number of people in critical care across New York City, the New York City Health and Hospital System by date. And the most recent recorded number, 517, was still above the desired threshold that has been determined to indicate adequate hospital capacity to enable easing of mitigation measures. And this milestone has not been reached, but the number of people in critical care has been gradually trending downward during the past 10 days or so, so that is still encouraging. But as some of you may be aware, there are patients with COVID-19 that can persist requiring ventilators and other life-sustaining measures for quite a long period of time. So it's been a little harder to disposition patients out of the ICUs. So looking at one of our more recent articles that came out in the Morbidity Mortality Weekly Report, looking at estimate of excess deaths in New York City. And we're looking at numbers from March 11th to May 2nd. So this is looking at confirmed and probable COVID-19 associated deaths. We have found that this really only included deaths that are directly associated with SARS-CoV-2 infection. It doesn't really account for deaths in person with chronic health conditions that are at increased risk of severe COVID-19 because they may not be recognized as attributable to COVID-19. So we looked at excess deaths that have been occurring during widespread community transmission of the dates from March to May, and then comparing that to the seasonally expected baseline of deaths for reported all causes. And so looking at this, as you can see, we've had a significant number actually of excess deaths. So we have 3 lines here. So the dark blue is our number of confirmed deaths. So that's laboratory confirmed deaths. And the lighter blue is those 5,000 in additional probable or assumed deaths due to COVID-19. But then above that, we've had really an additional, more than additional 5,000 additional or excess deaths in this same time frame compared to historical baselines. And this doesn't necessarily mean that it is these excess deaths are caused by COVID-19 itself. It could also be due to other factors such as delays in care for medically complex conditions, people staying home for fear of seeking care in the healthcare system due to fears of infection and other causes. So this is just the first step looking at some of these, kind of deeper impacts of the pandemic that we're just starting to uncover and look at. So what are the implications of this estimate of excess deaths in New York City? So physical distancing, demand on the healthcare system, and public fear might lead to delays in obtaining life-saving care. This is a very good time and a good reminder to all of us to remind patients that some symptoms always require immediate care, including trouble breathing, persisting pain or pressure in the chest or abdomen, cyanosis, alteration of mental status, or symptoms suggestive of a stroke. And advise patients with risk factors, in particular with or severe COVID-19, to notify their healthcare professional if they develop symptoms of COVID-19 to enable prompt evaluation and escalation of care if needed. And consider, and we'll talk about this a little bit more later, but consider proactively contacting patients to support chronic disease management during periods of physical distancing. And we're actually very happy to announce that we have some updated guidance that has recently been released through our health alert system. So this is related to our extended duration of isolation and monitoring. So our recommendations for period of isolation while ill with confirmed or suspected COVID has now changed to align with the CDC and New York State recommendations. So first we'll look at asymptomatic people who test positive. So our recommendation is for asymptomatic people that did test positive for COVID-19 by PCR should isolate and monitor their health for at least 10 days. And that's compared to our previous guidance of 7 days at home. And this is from the date of the first test being done. And after 10 days, they can discontinue monitoring unless symptoms consistent with COVID-19 develop. And if symptoms of COVID-19 develop during monitoring, follow guidance for symptomatic patients, meaning the clock starts for time in isolation from the beginning of the onset of symptoms, which we'll go through next. So for non-hospitalized patients with COVID-19, the CDC updated guidance on discontinuing home isolation for non-hospitalized people with possible or confirmed COVID-19. And now at minimum duration of isolation is recommended to be at least 10 days after symptom onset and with absence of fever for at least 3 days without antipyretics. And overall illness has improved. And for hospitalized patients, and again, this is in line with New York State's guidance. So in addition to meeting the above criteria for fever and improved symptoms, the patient should remain isolated for at least 14 days after symptom onset. And patients discharged from a hospital to a nursing home must first have a negative result on a COVID-19 diagnostic test. And that is based on the New York State Executive Order from May 10th, which you can find on the New York State website. And continuing looking at our recommendations for the isolation of vulnerable populations, additional precautions for people with certain risk factors are recommended, including isolation for at least 14 days or negative molecular testing for SARS-CoV before discontinuing isolation. And this applies to more vulnerable populations, including residents and employees of long-term care facilities, residents of facilities for people with developmental disabilities, and residents of supporting housing or shelter settings in which individuals share bathrooms, kitchens, or sleeping areas where we have unfortunately seen quite a bit of impact from COVID-19 outbreaks. So persons with chronic illnesses that may, where the illness may compromise immune response, including chronic lung, heart, kidney, or liver disease, obesity, and diabetes, also should apply to the 14 days of isolation. And severely immune compromised people, for other reasons, such as receiving chemotherapy, we highly recommend using a test-based strategy to discontinue isolation precautions in these groups. And if you would like to take a closer look at these, this is from our health alert, which was released yesterday, and you can find those on our website. So now I'm going to talk a little bit about just starting to look ahead in terms of what we might be expecting over the next several months. So some of these graphs may be familiar to you. So really the way we're looking at forward planning is really modeled after pandemic phases based on our previous historical experiences with influenza. So you will see that the first graph is actually graphing out the waves. It's basically the epi curve of influenza cases during the pandemic influenza 1918 outbreak, or the Spanish flu. So this is just to kind of show you an example of the wave theory. So actually the first cases of the Spanish flu started in March 1918 at a military camp in Fort Riley, Kansas. And so there, as you can see, there was a bump of influenza activity that was certainly outside of the normal rates. And this sporadic flu activity spread unevenly throughout the US, Europe, and possibly Asia over the next 6 months. And keep in mind that this was also during the middle of the First World War. Then there was a lot of troop movements between the US and Europe in this kind of subsequent period. And then in September of 1918, we started to see hints of a second wave that emerged at Camp Devens. And unfortunately, between September and November, there was a massive, much larger second wave of flu peaks in the United States. And that led to estimates are saying about 200,000 deaths during the second wave. And then unfortunately, after things were calming down and this is only 10 months after the initial cases were identified, in the beginning of 1919, there was another subsequent wave, fortunately not as big as the second, but still very impactful, especially on certain parts of the country. So just to show you, when we talk about waves, this is what we're referring to. And so based on that, the CDC had created this pandemic and response framework for novel influenza A, which is what a lot of preparedness work has been based on for pandemics. So looking at the pre-pandemic intervals of investigation and recognition, meaning those early days, when you're just starting to notice that something isn't quite right and trying to figure out and recognize what the threat is. And once you recognize the threat, you're looking for it closely to see if it's gotten into your country or community. And then once you start detecting cases, you go into initiation phase, and we will talk about the next slide, what goes with that. And then there's acceleration, eventual deceleration of the epi curve, and then we go back into a preparation mode for potential subsequent waves. So this is looking at New York City in the context of COVID and how we expect or think things may play out using this model. And this is from Vital Strategies, a group that has put out a COVID-19 playbook under Bloomberg Philanthropies. And so this model, looking at, again, the beginning where we had no cases, so that was back in late December, early January, when we started to recognize that something was going on. And, astute clinicians and public health partners started to realize that we needed to start preparing. And then we did start to see sporadic cases in the US, starting in Washington and quickly in other areas. And unfortunately, as we all know, during containment phase, where we normally would have been rushing to identify, do contact tracing, identify and test, unfortunately, during this particular scenario, as you all know, we did not necessarily have all the tools in terms of testing to be able to recognize and contain as well as we would like to have. And so then once containment really, you are kind of reach a point where you are unable to do aggressive contact tracing and find all the cases when you start getting into magnitudes of hundreds and thousands of cases. And then we do go into the mitigation phase, which is where we were in March when we implemented the New York On Pause program. And so this is really the period when we have widespread local transmission to the point where we are unable to do aggressive contact tracing. And so you do your best to mitigate the impact on the healthcare system and society. And if somebody comes in with or develops a COVID-like syndrome, you are working under the assumption that it is COVID-19 and treated accordingly. And so now that we are, fortunately over this kind of dark blue period, over the wave, and we are going down into the deceleration phase where we're seeing declining transmission, we are now getting revved up to implement the test and trace program, which is going kind of back into that containment mode, where we will, plan to have an army of contact tracers in New York City and ramped up testing capabilities where we will be able to more aggressively identify cases or SARS-CoV-2 positive patients, and we can do interviews and find out their highest risk contacts, and then ask them to quarantine if they do not have symptoms to prevent asymptomatic transmission, or ask them about symptoms. If they have symptoms, they will be isolated and tested, and so on and so on. And that is the plan and really essential to containing this epidemic. And so just wanted to, again, point out there is always the potential for, these subsequent waves, as you'll see these bumps in the pink line. And unfortunately, as social distancing measures continue to be relaxed, we have already seen in parts of Asia and Europe, there can be increased activity of COVID-19 as social distancing measures become relaxed. So these are things that we are being very vigilant about, which is why we are being extremely careful and science-driven in our decisions on when to start relaxing these measures. And then going forward, hopefully in the not too distant future, when we have potential very effective treatments or vaccine, where we can really feel comfortable that we are able to control transmission, then we can start really going into recovery mode and building back a better system once and for all. But in the meantime, we still all need to maintain vigilance and preparedness for subsequent potential waves. And so the implications of deceleration and preparing for suppression. So hospitals, will gradually expand services based on state and local guidance, phasing back in elective procedures, deferred cancer treatments, and other services, and again, continue to maintain ready for a second wave, including maintaining potential surge spaces that can be rapidly converted, et cetera. Long-term care, unfortunately, is going to be entering a phase of a new normal, where we really have to have aggressively increased surveillance and response capacity for vulnerable populations that may be very vulnerable and may have an atypical clinical presentation. So measures are being implemented, increasingly every week or so to really start doing our best to better protect our vulnerable long-term care patients. And the outpatient, which we'll talk about in more detail, we will begin to start reestablishing services while optimizing telehealth, adjusting to a new normal, including more regular use of PPE, and really get into day-to-day practice using triage processes. Emergency medical services, our EMS, will have the new normal of providing care in a COVID-19 environment where it's going to be really difficult to discern who may or may not be infectious. So different PPE requirements and screening requirements may be needed. And there will be continued build out of services and partnerships we can support 911 surge, such as access to potential 911 triage to telemedicine service and other innovations. And again, specialty services such as dialysis may see a potential increase in volume with patients that suffered acute renal injury during hospitalization and acute illness, need then to transition to the outpatient setting. Pediatricians will need to think about catching up on immunizations, and there's going to be a lot of impact from post-COVID ICU hospitalizations, including post-ICU syndrome patients that will require some very aggressive rehabilitation and other outpatient services or facility-based services as they transition back to hopefully a normal life. So looking at a spotlight on ambulatory settings today, outpatient practices, very interestingly, contrary to what the hospitals in New York City experienced, outpatient practices were severely impacted in a very different way, meaning utilization was down in both independent practices and federally qualified health centers by about 50%, and that's even with the transition to telemedicine. So unfortunately, there's been a major tragic financial toll on our outpatient providers. So it's really important that we help support them and get them back up to operational speed as best as we can. And it's essential to maintain primary care services, especially in the hardest hit areas of New York City, where we, in Queens and Bronx, and other hard hit areas, so we can ensure follow-up care and care in the most impacted and vulnerable communities. Our primary care clinics are absolutely essential to that continuum of care. They will also have a crucial role in the next phase of suppression as we really ramp up testing and tracing. And we just want to, of course, mention that there is a potential for reopening surge. There's going to be probably a huge backlog of patients, as we talked about earlier, who have been deferring care and deferring services that may need to really rush in to get care as soon as clinics start to open up. So just something to be thinking about. But it's still really important as we, looked at those potential for subsequent waves. It's really important to reopen the faucet gradually and thoughtfully. So, make sure that you're reviewing and looking at your plans on how to do that. So some considerations for reopening. Again, for primary care and outpatient practices, we still highly recommend you continue to maximize your telemedicine options as appropriate. Right now, fortunately, there's a lot of CMS waivers that have really allowed the expansion of telemedicine. So start thinking ahead about, what happens if and when those waivers are taken away and you have to go back to normal compliance with HIPAA rules and other things. So really shore up and strengthen your telemedicine system. We recommend you develop prioritization policy for in-person visits, really prioritizing number one, sick visits for potential high-risk COVID-19 patients, and that could be either telemedicine or in-person. Looking at your high-risk chronic diseases, including behavioral health conditions, delayed preventative services, and previously canceled or postponed visits, and looking for your patients, vulnerable patients or high-risk patients that were lost to care. We recommend spacing out your schedules with extended hours so you can decrease crowding in your waiting rooms. We all know New York City, we don't have the luxury of space, unfortunately, so that's going to be a big challenge. So you can try, certain techniques such as, having one in-person visit spaced out with 2 telemedicine visits, things like that, or having hybrid visits where you do most of the assessment and a telemedicine visit, and the patient could come in separately just for labs or vital checks to help reduce time in the clinic and crowding. Also want to think about, kind of similar to the concept of grocery stores having senior only hours early in the morning, you could consider something similar for your highest risk patients, having special early hours when the clinic is nice and clean from the day before, and consider if kind of the local epi in your space allows for it, potential cough clinic hours later in the day, ideally at the end of the day, where you can assess potential COVID patients. And then, really now that we are going to be relaxing testing guidance, develop your COVID-19 testing policies and procedures. How are you going to be doing that safely and effectively? Whether that means something like a model with the hybrid visits where you do telemedicine assessment and just bring them in for targeted testing. Just think about how you're going to execute this safely. And also, how are you going to, can you maximize patient self-collected samples such as nasal, anterior nasal sampling that does not require a healthcare worker to utilize PPE and be in the room. Thinking about how making sure that you have, before you open up, ensure you have appropriate staffing to support services and safeguards that need to be in place, security guards, triage staff, etc. And really have a good plan for how you're going to communicate with patients, staff, about, what are, especially with your patients, what are the expectations when they come in? You expect them to wear a mask, how to get to the clinic safely without causing any unnecessary exposures, etc. And what is kind of the new policies, how to get them set up for telemedicine, etc. Also, how are you going to communicate with public health? We'll probably be going back soon to a model of reporting, potentially at least clusters or other cases. So just make sure you have a good plan for keeping up with reporting requirements and how to communicate and work with public health partners. This is something we're actually going to talk about in much more depth, not next week, but the week after, but looking at how to, just a deeper look at how to prioritize patients for outreach and care, really have a comprehensive risk stratification, and we're going to be introducing some tools on how to do that in the next week or so. And this risk stratification can really help practices prioritize patients for outreach and direct resources as needed, so you can really find the patients that need to be educated on telehealth and that could potentially utilize it better. Make sure you're following up on care plans that may have been deferred, discuss changes in health and/or lifestyle, follow up on visits to specialists, and follow up on any ordered referrals and tests better. So just the infection control considerations for reopening, staff, we all get rusty. Practice makes perfect, so it never hurts to do additional staff trainings on both PPE, donning and doffing, infection control measures, but also, make sure that you're doing, staff huddles or offering staff education to stay up to date on the newest treatments and medical updates for COVID-19. For the safety of your staff, you should not open up unless you can have supplies assured, appropriate supplies. That includes PPE, hand hygiene supplies, appropriate cleaning products, since you'll, really need to be very cognizant of your environmental service protocols, and also testing supplies as you need it. Start to think about, if you haven't already, what are some of the engineering controls you can put into place to reduce unnecessary exposures, things like having plexiglass barriers installed at triage desks. Some people have implemented, testing pods where that protects the healthcare worker from a face-to-face encounter when they're testing or doing sample collection. Can you utilize portable HEPA filters to create better airflow or potential negative pressure room to do procedures, things like that can help really optimize the safety of your clinic. Really think about, develop and review your triage protocols based on the newest symptoms and case definitions, and really still want to make sure you're limiting visitors into the clinic or companions to only the absolute necessary. Utilize source control. So this is really important. We will still continue to recommend universal face masks, especially in the healthcare settings. And of course, patients, when they come in, should all be wearing face coverings or face masks. And this is really important because if all the healthcare workers and all the patients, and so basically, if there is source control on both sides of an interaction, according to the CDC risk assessment for potential exposures, if a patient does end up being positive for COVID-19, if both parties are source controlled with a mask or face covering, then that is a low risk exposure and you do not have to furlough your staff. They can remain at work with self-monitoring. So I really encourage you to take a look at the CDC guidance on healthcare worker monitoring and exposure assessments. Also, again, how are you going to implement physical distancing measures in your clinic? Don't forget about your elevators and entryways. Have lots of signage reminding people to stay apart, have markers on the floors, space out your chairs, block out areas on benches. Can you put in curtains in your waiting rooms, things like that to maximize social distancing. Support employee health. Again, think about how, if you had to do, a risk or exposure assessment, how would you do that? And really, really important, I know we keep hammering this, but, mental health services, employee wellness, staff burnout, how are we going to support, support our staff to be healthy and safe in their work environments, both mentally and physically. And also, of course, thinking about subsequent waves as we're reopening. Can you designate COVID-19 or cough clinic type spaces, separate entrances, separate waiting areas, maybe have a triage tent outside, depending on what the local epidemiology in your area looks like. So then just a quick word about managing high-risk COVID patients. Again, thinking about the data, the excess deaths that we have been seeing, how do we make sure that we are bringing in the right patients for the right care at the right time? That could be potentially high risk for COVID complications. So really, it's important to give all patients with possible or confirmed COVID education on symptoms and what to look for to seek urgent care. And there's really that high risk window at about 1 week to 10 days after symptom onset, where we have seen really rapid decompensation. And dyspnea, even mild dyspnea, needs to be kind of watched closely because that can already be a sign of hypoxia. So really identify closely patients with COVID-like illness, the highest risk patients, including those with underlying medical conditions or over 65. Also be thinking about, are there social concerns that could impact their ability to isolate at home or take care of themselves at home. Maybe they don't have anybody that can help them get groceries and help them cook and take care of themselves. And my colleague will be talking about this, some of the options more. Are they in a congregate living situation? Just, make sure you're thinking about these other considerations when you're telling them they could manage at home. Assess signs and symptoms, of course, the vitals, O2 saturation. Is this somebody that may be appropriate, to come in to get their vitals checked, or can they be assessed at home? Chest X-ray, labs, flu tests can also come into an assessment of somebody you're particularly worried about. And then, of course, testing, depending on what resources you have at your clinic, prioritize first and foremost PCR testing for the highest risk patients. But of course, if the PCR is negative and you still have high suspicion, just treat as COVID until proven otherwise, which is never. And antigen testing is helpful. This is the new antigen testing coming out. Still has not great sensitivity, but very good specificity. So the antigen testing can be really helpful if it's positive, but not so helpful if it's negative, and you may need follow-up tests on that for a negative antigen test. And just as a reminder, serology is not a diagnostic test for acute SARS-CoV-2 infection. And then think about how you're going to risk stratify these patients and monitor based on those risks. Come up with your monitoring plan. Do they require an urgent referral with red flag signs? Can they be monitored at home versus would they be appropriate for isolation hotels, which we're going to talk about? Develop a follow-up plan. What is your follow-up plan? How often are you going to check in? Do you have team members that can do those check-ins? Are there home monitoring resources that you can provide to your patients? Oxygen monitors, blood pressure cuffs, etc. Would it be appropriate to try and provide home oxygen or concentrators or other home therapies to them? And so, last, we just want to emphasize that we still need to be prepared for new and old challenges. So the new reality is really going to be, we're going to be practicing in a very different environment. So be ready for difficult conversations with your patients. Have a very low threshold to talk about advanced directives, even in people that you normally would never have considered it. Any of these high-risk patients, it's really better to talk about it now than when they're in the ICU. Really be ready for, there's going to be a lot of trauma. The impact of trauma is going to be seen for a long time, I think, not just from COVID-19 complications and hospitalizations, but also the traumas from the quarantine, losing jobs, losing housing, domestic violence, depression, etc. A loved one being impacted by the severe COVID infection, etc. So really, start thinking about, how are you going to change the way this integrating social and mental health services, and think about, start looking at what are the post-discharge management needs of patients that are coming out of hospitalization from COVID, especially from the ICU that may have increased and complex home health needs, et cetera. And also, of course, we're hoping for the best for the summer, but be prepared. We are doing a lot of planning around potential summer heat emergencies. How to provide air conditioning or cooling to vulnerable patients that may need to shelter at home or cannot be in a congregate cooling center. Think about coastal storm season. There still could be power outages. How would you manage those issues? We still may continue to see shortages of medications and supplies. Make sure you're preparing for that. And of course, if we still have circulating COVID-19 during influenza season, that's going to be a double whammy in terms of patient surge and impact on your space, staff, and supplies. So keep those things in mind, how you would deal with it. But I don't want to be a Debbie Downer, so I want to remind us that there is actually some positive things that we hope will come out of this, and how do we build back the system better and more resilient. So this has really been a time of incredible innovation. We are continuing to share best practices and lessons learned, and I think that's going to be a continued great resource, peer sharing. There's this continued expansion of telemedicine and home-based options for care, which is wonderful, I think, for both the providers and the patients to have more options. There's been a major spotlight, of course, on national and local health disparities. So really, I think it's on all of us, from the provider to the DOH and the other city systems. How are we going to better address social determinants of health? And we really need to and are paying real close attention to how we can shore up our safety net systems and access to healthcare. And I think that's really important for us all to think about. And we've really started to realize the value of population health, I think now more than ever, and how can we continue to fix our, try and look at fixing our fragmented healthcare system and really optimizing population level data to improve outcomes in our communities and society. And of course, last but not least, we've unfortunately, as physicians, been in a bit of a downturn, or providers have been in a bit of a downturn in terms of public trust and misinformation. And we really have seen at least a significant degree of renewal in public trust and faith and respect for medical professionals, including physicians, nurses, and all our amazing, wonderful frontline providers that are in this audience and throughout our city and country. So again, we just want to thank you for all your work and all that you've done. And we're so glad to be on this journey with you, and we hope we can all build it back better. So I just wanted to leave with one parting thought, that there are dark shadows on the earth, but its lights are stronger in the contrast, and that's from Charles Dickens. And I'm going to then turn it over to my colleague, Dr. Elgendi, to talk about the hotel program.
Yes, thank you so much. So I wanted to provide a high-level overview today of the COVID-19 hotel program, which is really critical to both the mitigation and suppression phases of the pandemic. Possible to go to the next slide? Thank you. So the goals of the COVID-19 hotel program are to protect communities that are disproportionately impacted by COVID-19, as well as to reduce the spread of COVID-19 within the home, especially in communities that are at high risk. The intervention itself involves free hotel rooms for people who need to isolate from household members due to COVID-19, but cannot do so where they live. And some of the criteria that we use to determine whether somebody can or cannot safely isolate at home are inability to maintain 6 feet of distance between the patient and other household members, inability to separate or rather lack of a separate bathroom, or inability to clean and disinfect the frequently touched surfaces such as faucets, handles, etc. after each use. And if the patient needs to use a shared kitchen and is unable to clean and disinfect that kitchen area after each use. So if you decide to participate in this program, we'll give you some more information on how to know whether somebody is appropriate for isolation. So we can go to the next slide. So I wanted to also give just a general overview of the process for accessing COVID-19 hotels. So first, a provider who has enrolled in the program identifies a patient either during an in-person or telemedicine visit with COVID-19 symptoms who cannot self-isolate where they live. And that's based on some of the criteria I just mentioned on the prior slide. The clinician will receive a provider referral checklist upon enrollment in the program. So they would use that provider referral checklist to determine appropriateness for placement. And I'll talk a little bit about the criteria for that checklist in just a moment. And after using the checklist with the patient or running through the checklist with the patient, the provider would call 1-800-673-6109 to validate the checklist and the results with an on-site clinical staff member. The clinician would then ensure that the patient has enough prescription medications to last 2 weeks, or the typical duration of the hotel stay. Prescriptions can be transferred to a pharmacy near the hotel or to an online pharmacy service as necessary. If the patient meets criteria, the provider can book the patient for the hotel using New York City Emergency Management's booking process. And for those providers who decide to enroll in this program, there is an onboarding process. So we would walk you through how to make those reservations. And finally, if the patient receives in-home supportive services, such as visits from a counselor or other mental health services, the provider would work with the patient to arrange for continuity of such services in the hotels. and remote provision of services is completely fine. That can be telephonic, that can be through video means, etc. So as I mentioned, providers would use a checklist that's given to them upon enrollment in the program, and they would use this checklist to assess the following circumstances or criteria as they relate to eligibility for the hotel program. So in a general sense, these categories or criteria are in the medical area, so having to do with activities of daily living and other basic medical questions, psychiatric health, as well as substance use questions. So if the patient does not meet eligibility criteria for the COVID-19 hotel program, the provider may contact the New York City Emergency Management Clinical Screening Center at 1-800-673-6109 for possible review of circumstances and assessment for alternative placement. So that could be a hotel that has a higher level of medical services available. And to go to the next slide, I'll talk a little bit about the service provision that's available at the COVID-19 hotels. So these are generally speaking, these are low acuity, these hotels are intended for low acuity patients who are generally medically stable. So guests in these hotels will receive 3 meals per day delivered to their room, as well as local phone and Wi-Fi services, which are particularly important to help patients stay connected to friends and family, as well as to continue receiving telemedicine visits as needed. Vital sign checks will be provided 2 to 4 times per day through nursing staff that are available at the site, at the hotel. There is some medical services via on-site, or rather providers, enrolled providers would need to provide medical services via either on-site visits or telemedicine visits with the provider. So if you're referring a patient to the hoteling program, we ask that you continue to follow up with that patient for the duration of their stay in the hotel. And that can be, again, through the telephone or through video means. And then pharmacy services for any regular or chronic care medications, which can be delivered to the room by a nurse. There's also 24-hour nursing services for emergencies or questions. So again, the hotel is really intended for medically stable patients, but we do have medical staff, particularly nurses on site, in case any issues need to be elevated. There's also some case management assistant on site by way of social workers. And there is some education on the importance of self-isolation in reducing COVID-19 transmission. So upon checking into the hotel, patients would receive some literature about the importance of self-isolation, as well as ways to cope with isolation in the hotel. And finally, NICEM provides transportation to and from the hotel if needed. So guests do need to bring a couple of items with them. That includes personal items such as necessities like toiletries and clothing, as well as any other items that would help them pass the time during their isolation. So that could include books, magazines, phone chargers, etc., as well as bringing 2 weeks worth of prescriptions and over-the-counter medications, including medically assisted treatment as appropriate. And then, so if, as I mentioned, providers need to enroll to participate in this program and to be able to refer their patients. So if you are, in fact, interested in enrolling, you can email your NYC Reach representative or nycreach@health.nyc.gov with the following information. So the name of the organization, contact name, email, phone number, organizational NPI number, type of setting, whether that's primary care, community health center, etc., a description of the patients served by the organization, so that could be adults, family, pediatric, or other, zip code or of service catchment area, and then whether there's an affiliation with an independent practice association or other professional associations, and whether you want to be considered a Category A or Category B provider. And I'll briefly describe what those distinctions are. So for Category A providers, this includes providers who accept both new and established patients and do not balance bills for COVID-19 hotel-related care. These providers will be listed on the COVID-19 hotel program webpage and may be contacted by new and established patients interested in accessing a hotel. Category B providers would include those who intend to accept only established patients and or who intend to balance the bill for COVID-19 hotel-related care. And those providers are authorized by the New York City Department of Health and Mental Hygiene to refer their patients to COVID-19 hotels, but will not be listed on the COVID-19 hotel program webpage. And the webpage is located at the bottom of this slide. And I believe this slide deck will be made available to participants, so you're able to take a look and see which providers are listed, and then determine whether you'd like to be a Category A or Category B provider. Thank you so much.
Thank you very
Hi,
much.
can you all hear me?
Yes, go ahead.
Okay, thank you. I'll be speaking today about what is now being called multi-system inflammatory syndrome in children, abbreviated MISC. Next slide, please. So in late April of this year, providers in the United Kingdom reported a newly recognized pediatric syndrome of multi-system inflammatory syndrome, which they referred to as PMIS. They described the patients as having overlapping features of toxic shock syndrome and atypical or incomplete Kawasaki disease, and found that some, but not all, were positive by PCR for SARS-CoV-2. Shortly thereafter, the New York City Health Department identified similar cases by outreaching to pediatric intensive care units. And on May 4th, we issued Health Alert number 13, asking providers to report to us what we referred to as PMIS. And we asked for reports to come if a patient was under 21 years of age, had 4 or more days of fever, and either incomplete Kawasaki disease, abbreviated KD, typical Kawasaki disease, or toxic shock syndrome-like presentation with no alternative explanation. Then on May 13th, New York State issued a health alert, also on what they referred to as PMIS. And finally, yesterday, or today, I guess, it's actually a mistake, sorry, I think it was yesterday, the 14th, the CDC issued Health Alert number 432, in which they referred to this syndrome, but gave it a new name, which is multi-system inflammatory syndrome in children, or MIS-C. And that is how we will be referring to it moving forward. They also, in their advisory, issued a case definition, which is really intended for to try to standardize across the country how different health departments count cases. But different health departments will call for reports according to their local epidemiology and public health decision making. Next slide, please. So because Kawasaki disease is referenced frequently when speaking about this syndrome, I want to just take a minute to go over Kawasaki disease. So Kawasaki disease is a syndrome that involves inflammation of the medium-sized blood vessels throughout the body, and it is typically seen in children under the age of 5. It is thought to be to be the result of an infectious agent that triggers a cascade of inflammation in the body that results in the vasculitis. But the exact etiology is unknown. It is defined as fever for 5 or more days and at least 4 of the following 5 criteria: bilateral bulbar conjunctival injection, so that's essentially the whites of the eyes, oral mucous membrane changes. Most characteristic are sort of bright red or fissured lips, an injected pharynx or strawberry tongue, peripheral extremity changes, including erythema of the palms or soles or edema of the hands or feet, as well as periungual desquamation in later phases, a polymorphous rash, and cervical lymphadenopathy with at least one lymph node being 1.5 centimeters in diameter or larger. So typical Kawasaki disease is fever for 5 or more days and at least 4 of those 5 criteria. Incomplete Kawasaki disease, as it sounds, is fever, but with only a subset of those criteria. So fever with 5 or more days with only 2 or 3 of those 5 findings above. And finally, an entity referred to as Kawasaki disease shock syndrome is Kawasaki disease, either typical or incomplete, with hemodynamic instability. In other words, decreased peripheral perfusion or hypotension. Next slide, please. So the symptoms that are seen in MISC are still being defined. The full breadth is not yet known, but from what we do know so far, they seem to be the symptoms that you see in Kawasaki disease, either typical or incomplete, that subset. But they also have some other common features that we've noticed, which includes, in addition to the fever, abdominal pain, diarrhea, vomiting, conjunctivitis, and rash. So conjunctivitis and rash are part of the Kawasaki spectrum. And you certainly can see children with Kawasaki disease who have abdominal pain as well. But this has been to the clinicians who have seen these cases and the case reports that exist, the abdominal pain and these other symptoms are prominent. Next slide, please. So I also wanted to just quickly review a paper that came out 2 days ago from the pediatric intensive care investigators in Bergamo, Italy, which was the epicenter of the Italian COVID-19 outbreak. And what they did is they looked at the frequency of Kawasaki disease at their center, and it's the largest pediatric center in northern Italy and the largest PICU in northern Italy. They looked at patients who had presented to their center with what they called Kawasaki-like disease, which was a combination of typical Kawasaki disease and incomplete Kawasaki disease. And they looked at the cases that they had seen in the 5-year period before the COVID-19 outbreak started there, which is estimated to be in early February. And over that period of time, they saw 19 cases, which has amounted to an average of 0.3 cases, not even 1 case a month. The children were, affected children had an average age of 3 years. There was a female preponderance, 63%. And the majority, almost 70%, were typical Kawasaki disease. And 31% were incomplete Kawasaki disease. And none of these 19 children over this 5-year period had any hemodynamic instability. However, in the 5-week period after February, when COVID-19 broke out in Italy, in this area, they saw, in a 5-week period, they saw 10 cases, which amounted to an average of 10 cases per month. And these children had a mean age, average age of 7.5, and were predominantly male, 70%. They were half atypical or incomplete Kawasaki, and half of them had Kawasaki disease shock syndrome. And that was seen in both atypical and in typical Kawasaki disease clinical presentations. The children had elevated inflammatory markers, including fibrinogen, ferritin, and troponin. Not in all, however, only in some. And SARS-CoV-2 was detected in only 2 of the 10. However, SARS-CoV-2 serologies were positive in 8 of the 10. And it was very clear to the investigators as they described that these cases are clinically distinct from the cases before the arrival of COVID. They were older, and they did have respiratory and GI involvement, as well as meningeal signs and cardiovascular involvement, compared to the cases of Kawasaki disease seen before. Next slide. So I wanted to take a minute to review the CDC MISC case definition because it is something that has just recently been put out. They are asking that people consider the case definition, that local health departments consider defining these cases of MISC based on age of 21 years, under 21 years of age, in children presenting with fever, laboratory evidence of inflammation, and evidence of clinically severe illness requiring hospitalization with multi-system, 2 or more systems involvement. So either cardiac, renal, respiratory, hematologic, gastrointestinal, dermatologic, or neurologic systems. And there being no alternative plausible diagnosis or diagnoses for this presentation. Part of their case definition also requires that the patient have SARS-CoV-2 positive PCR or antigen, or have a history of exposure to COVID-19 within 4 weeks prior to the onset of symptoms. And they have a variety of footnotes and comments that accompany this case definition. But again, I wanted to emphasize that this is what CDC wants health departments to use so that we can sort of measure the burden of disease in a standard fashion across the country. But it is different from what a health department may ask providers to report. Thank you. Next slide. So in terms of what we've done and are doing, we are currently investigating all reported, and I say here cases, I should really have said all reports of potential cases, because again, we have asked providers in New York City to report to us, as I described on the first slide, and what can be found in our current HAN. And New York State has also asked actually for a broader set of case types to be reported. And those are potential cases, and we are going to investigate all those reported potential cases. And we are reviewing the medical records and abstracting information from them so that we can put together all the information we have from all the cases occurring across all the facilities in New York City and try to learn from that what the clinical picture is, to refine our understanding and our ability to communicate with providers about what to look for. We have done provider education and outreach about how to identify these patients, and we are describing the local epidemiology and reporting, of course, to key stakeholders, including City Hall, what we are seeing regularly. But we have been in touch with PICUs, hospitals, and providers, and if there are any PICU folks, intensivists on this call, they will know that we have been in touch frequently and consistently to find out about any new cases that have been admitted. We have done some public education and outreach. We have a fact sheet aimed at parents and caregivers, and the link is there. The Department of Education and the rec child care centers have gotten a dedicated communication from the health department. The rec child care centers are child care centers that are have been kept open and are designated for the care of essential workers during this period of time. We are working also on a media campaign and coordinating with CDC. Next slide, please. So as far as what's been reported to the New York City Health Department as of yesterday afternoon, we have had 110 patients who met reporting criteria for multi-system inflammatory syndrome, as we have been calling it. 59 of those, or 54%, tested positive for COVID-19 by either PCR or serology. 38 were positive by PCR only. 16 were positive by serology only, and 5 tested positive on both PCR and serology. 32 were negative by PCR and or serology, and 19 had no test results. There has been 1 death, sadly, reported. So with these reported potential cases, we will then apply a standard case definition And the case definition we use will, of course, impact what our case counts are. Next slide, please. Out of the 110 reports, 35% or 38 were under the age of 5. However, another 25% were aged 5 to 9, 24% aged 10 to 14, and 16% aged 15 to 21. So this is a very different distribution from classic Kawasaki's, which, as I mentioned, is typically under the age of 5. There has been, at 56%, a female preponderance. Next slide, please. This is looking at the first geographic distribution of these cases, and followed by the race ethnicity distribution. So the Bronx had the highest proportion of reports to us at 38%, Brooklyn 22%, Manhattan 6%, Queens 31%, and Staten Island 3%. In terms of race ethnicity distribution, the largest number of reports that we received came with regards to patients or children who were Black, African American. Then second to that was Hispanic Latino, followed by Asian, white at 9%, other at 5%, and we are still investigating race ethnicity, obtaining race ethnicity information for a substantial proportion, almost 40% of reports, because they don't necessarily come in on reports, and we have to try to triangulate other data sources to get that information if it's also not in the medical record. Next slide. So something I think really important for us to bear in mind as we think about this syndrome is that while it is definitely temporarily associated with COVID-19 infection, that what relationship it has with the virus is not yet defined. It seems very likely that it is in some regards caused by the virus, or that the virus is triggering something that results in these clinical manifestations. But whether or not it is seen, you know, with acute infection, or whether this is just a post-infectious manifestation or something else, is really not yet understood. We are asking providers to immediately refer suspected cases to specialists in either pediatric infectious disease, rheumatology, or critical care as indicated by the child's condition. And it is really important that we, to the best of our ability, diagnose these cases early and initiate treatment early, because there is the risk for end organ damage and other long-term complications. And for those patients who do meet full criteria for Kawasaki disease, the standard treatment for Kawasaki disease involves the use of intravenous immunoglobulin and aspirin, and they should all be treated with that if they meet criteria for Kawasaki disease. And I know when we hear from our clinical colleagues, they'll say a little bit about how they have been treating the patients that they have been seeing in the intensive care setting. Next slide, please. And finally, reporting to New York City by New York City providers is required by both the New York State Sanitary Code and the New York City Health Code. Please call the provider access line at 866-692-3641 to report any patient who meets criteria for what we have called pediatric MIS up until now. And we will very likely be issuing revised reporting requirements. And these are references that link to earlier citations in the text. Thank you very much.
Thank you for the opportunity to present some cases. I'll be joined by my colleague, Dr. Chung, who's a pediatric intensivist and cardiologist at our center. Next slide. So this was a 3-year-old male who was previously healthy, who presented with 5 days of fever and a Tmax of 105. 2 days into his illness, he had seen his PMD, a rapid strep was negative, but a culture was positive, was started on amoxicillin. On the same day, he developed a non-itchy rash on hands and feet, some red lips, and some conjunctival injection. He did not have any cough or nasal congestion, though he did have emesis ×1. There was a reported history of COVID positive sick contacts 3 weeks ago, mom, whose only symptom was a cough. In the ED, when he presented to us, he was tachycardic with a heart rate of 144. He had rash and conjunctivitis, which was described as limbic sparing. Next slide. His admission workup was notable for white count of 13.91, hemoglobin of 11.6, and platelets of 170. Elevated white count has been a characteristic of many of these patients for us, and thrombocytopenia has been well described with acute SARS-CoV-2 infection. He did have elevated inflammatory markers, including ESR, CRP, ferritin, and procalcitonin at admission. His BNP was mostly notable just for hyponatremia, though we have seen acute kidney injury in some of these patients. Most notably is BNP and troponin were both elevated at 27,552 and 57. His echocardiogram at admission showed mildly decreased function in normal coronaries. Next slide. In terms of management, he was on vasoactive support for just 2 days, so he was able to be weaned off relatively quickly. He did require some oxygen support by nasal cannula, and a characteristic feature of these cases, probably distinguishing them from the previous cohort of COVID positive cases we had seen at our center, is that the respiratory requirements generally tend to be low. Very few or none of these patients have required mechanical ventilation. We have been using steroids, particularly at higher doses for the severe cases, led by a rheumatology division. And we have increasingly used intravenous immunoglobulin for kids, for children who meet either KD, incomplete KD, or have some evidence of coronary involvement on an echocardiogram. Was discharged on low-dose aspirin on hospital day 8, and at follow-up is doing well. Next slide.
Good afternoon, everyone. This is Dr. Chung. I'm going to be presenting the next 2 cases that we've seen at our institution. So the second case here is a 14-year-old young man who also, like the previous case, had moderate to high fevers for many days, for 6 days prior to coming to our institution. He was actually a telehealth visit because he had a right neck swelling that was getting progressively erythematous and more tender. And he was prescribed antibiotics in the form of amoxicillin and clindamycin over that telehealth visit. His symptoms then became more diffuse. He not only continued to have fevers, but he had abdominal pain, vomiting, and severe myalgias, and then a transient redness of his palms, soles, and areas of his trunk that he described in terms of this rash that he had. When he came to the emergency room, he developed hypotension and tachycardia. As Dr. Zachariah had mentioned before, hemodynamic instability and shock is often the reason for admission for these children, and less so the respiratory symptoms. And on his exam, in addition, he was noted to have conjunctivitis, as well as this right neck swelling that he had described before. Next slide, please. His admission workup was actually positive for the SARS-CoV-2 PCR nasal swab. He too had an elevated white count with a shift of 95% neutrophil predominance, and more strikingly, a lymphopenia, as you see here. Like many of our children that have presented with this syndrome, their inflammatory markers are kind of pretty elevated across the board. His CRP was 300, his procalcitonin was 2.8. This case was notable for a low albumin at present 0.7. And just like was described in the last case, some elevated cardiac biomarkers in the form of troponins and BNP. His echo only showed mildly diminished function, but his EKG did show a first-degree AV block with a prolonged PR interval, but otherwise a normal sinus rhythm. Next slide, please. He was placed in our ICU and required some pressor and inotropic support for just a few days. As was described by Dr. Zachariah, we have certainly used steroids in the form of methylprednisolone, particularly for our shock patients. And with the institution of that, his shock resolved and he was weaned off of pressors. Given the fact that he had this right neck swelling, he was continued on antibacterials, antibiotics for a full week. However, he was never documented to have a superimposed infection through blood cultures at that time, and he was discharged on hospital day 7 on a steroid taper. Next slide, please. And then I'll quickly go through a third case that kind of helps to just show how varied the presentation of this might be. This 7-year-old girl who has a Caucasian father and Asian mother presented with also moderate to high fevers for several days, 5 days. Her really kind of marked presenting symptom was really abdominal pain. You had heard before that GI symptoms has been a pretty common feature of this presentation. But in addition to that pretty marked abdominal pain, she also had a morbilliform rash on her face, trunk, and back. She was rapid strep positive at another emergency room before she was presented to us. So at that emergency room visit, she was giving a preceded dose of IM penicillin. But because her abdominal pain worsened and then subsequently localized to her right lower quadrant, and then had now progressed to pretty significant vomiting and diarrhea, her parents brought her to another emergency room. In our emergency room, she was tachycardic, she was lethargic. She was actually even evaluated by our pediatric surgical team to rule out appendicitis, which is not an uncommon story heard here, for localized right lower quadrant tenderness and rebound. It was noted that rash on her face, trunk, and back, as was described in her history. Next slide. Her SARS-CoV-2 PCR was positive from her transferring facility and was negative at our center. She had kind of a different hallmark of her presenting CBC. Particularly what was striking about it was really a 12% bandemia. Again, her inflammatory markers were elevated, including ESR, CRP, and ferritin, as well as an elevated BMP and troponin. And like her predecessors, her echo function was only mildly decreased and her coronary arteries were normal. Next slide. Again, because her abdominal symptoms were so striking, she had a more extensive abdominal workup, including an abdominal ultrasound that showed inflammatory changes of her right lower quadrant, particularly in her cecum and ilium, where they demonstrated wall thickness. And that prompted a further evaluation by abdominal MRI. The abdominal MRI showed extensive inflammatory changes of the right lower quadrant, indications of inflammation of her terminal ilium, as well as her rectosigmoid colon, as well as moderate ascites. Next slide. She was admitted to our ICU. This patient did not require pressors, but she was febrile. Her abdominal exam was concerning. She did have some kind of mild hypoxia that required oxygen supplementation, but we figured that she needed some kind of closer observation. She was started on methylprednisolone, 2 milligrams per kilo per day IV. And it was pretty striking upon the starting of the anti-inflammatories how much her abdominal pain and her rash improved in less than 24 hours. She was discharged on hospital day 5, also on a prednisone taper. She, as an outpatient, we had heard from follow-up that upon weaning of her prednisone, the rash did reappear, so her taper was prolonged. I'm sure there's many questions in the audience about kind of the impact of the myocardium as well as the coronary arteries in cases like these. She was one of our earlier cases, so we've had the ability to have a pretty extensive follow-up on her. An echo 2 weeks later showed that she actually had come back to normal ventricular function, as well as the fact that her coronary still remained normal in size. Next.
So as many of you are probably wondering how to identify these children and adolescents, I think from our experience, we have learned that multi-system symptoms are key. And the most common symptoms that we have seen in our patients include fever, which is usually high for several days. The median has been around 5 days for us. Predominantly, these children have presented with gastrointestinal complaints and not respiratory symptoms. So these include abdominal pain and guarding, nausea, vomiting, or diarrhea. And often it is an appendicitis type of picture. There's rash, which is very pleomorphic, which is the rash that's described in TD. and can manifest in a variety of ways, as some of these cases have illustrated. Conjunctivitis, as commonly reported. Less commonly, we have lip retina swelling. Some of these children have presented with neurological issues, including lethargy and headaches. Less common symptoms have included respiratory symptoms, including cough, difficulty breathing, cyanosis. There is severe myalgia, lymphadenopathy. These have included unilateral cervical lymphadenitis, which is described with Kawasaki disease, but also abdominal lymphadenitis on imaging, including eccentric lymphadenitis. We've also seen some focal deficits, seizures, and cranial nerve palsies. Thank you.
Thank you to all our presenters for all that great information. To our audience, thank you also for submitting your questions during these presentations via the Q&A portion of the WebEx. As you can see, many of our colleagues here at the Health Department have been addressing those questions, and it looks like we have a few minutes to put a few out to the group. Also, as a reminder, a PDF of these slides, as well as a recording of today's webinar, will be made available on our webpage following today's presentation, and you can find all that information as well as slides and recordings from our previous webinars on the webpage that is up on your screen right now.
I think our first question is for Dr. Rakeman. And we've gotten a lot of questions about how antibody tests and PCR tests relate to both immunity and transmissibility of COVID-19. Dr. Rakeman, could you give us a short answer on that? All right, it looks like we're having an audio issue with Dr. Rakeman. Dr. Foote, could you tell us, so you mentioned a lot about having adequate PPE. Oh,
Dr. Rakeman?
all right, sorry. Dr. Foote, you mentioned a lot about having adequate PPE supplies to meet the upcoming surges of the pandemic. Can you talk a little bit about what that looks like, and especially given the context of some of the strategies we're using to stretch our PPE supplies at the moment?
Oh, sure. I love talking about PPE in an unnatural vigor. So we're actually going to be, so stay tuned, because we are going to be posting an updated guidance for infection control and PPE recommendations for the outpatient setting. But generally, we recommend for close patient encounters, where you're in the room doing a clinical examination, to use droplet precautions, face shield, ideally, or other eye protection, and gloves. And if you are going to be in close physical contact, you can wear a gown. We certainly recommend extended use of your face masks, where you just wear it throughout the day, and you can actually, if your supplies are short, wear it over multiple days until it is soiled or wet or otherwise not functioning. And with the joys of the face shield is that it covers your whole face, so it adds additional protection and can be cleaned off and reused as well. And so we will have a lot more information about that coming out soon. Thanks.
So did we get Dr. Rakeman back? Okay. And then actually, if we could get you back again, Dr. Foote.
Hi, this is Jen. Can you hear me?
Oh, there you go.
Hi.
Would you like to talk about antibodies and transmissibility?
Sure. Sure. So there's a number of serology tests that are available. All of the serology tests that have an FDA emergency use authorization are tests that must be performed in a laboratory setting. There are no tests authorized to be performed in a clinical point of care type of setting. So that is something that should not be happening. There is a lot that we do not know about antibodies and immunity. So antibody testing is very useful from a public health perspective. It's very useful at a population level. It helps us understand how many people in a population may have been exposed or infected with the COVID-19 virus. What it does not tell us much at a single patient level, because we don't know that whether a positive test for antibodies, for IgG antibodies, for example, whether that confers or indicates that there is any level of protective immunity for that patient. All it lets us know is that that patient's been exposed and infected with the virus. So there should be no changes to behavior of a patient based on a serology result. A patient should still continue to use face masks. They should still continue to socially distance. Healthcare workers with a positive IgG test should still continue to use personal protective equipment, just like everybody else in that clinical setting. So
Thank you.
as we learn more, we will update, but as of now, we really don't know very much at all about the immune response to this virus. Thanks.
Thank you so much, Dr. Rickman. And then for our panelists who were talking about MISC, we've gotten several different questions about correlations with this syndrome. So we've gotten a question about whether vaccination or under vaccination has an influence on the development of this phenotype, about vitamin D levels, group A strep, and I think that, just about urinalysis and any sort of urinary tract infection.
So co-infections do, in our experience, we have seen positive streps in a couple. Parvovirus PCRs has been positive, but we're not sure if it's an reactivation versus an acute infection. And EBV serologies have also been positive in too. So I do not necessarily think that having a co-infection either on a respiratory PCR or a strep test necessarily means that you should exclude it, at least initially. And vitamin D, and I don't think any of our kids have been under vaccinated, if that is the hypothesis. I don't think we've had, that has not been a majority feature.
And yeah, this is Julie Schillinger. If I might just jump in, I think these are very interesting and good questions regarding vitamin D and immunization. But I think it's the sort of thing where we're going to need to have a reasonable number of cases. And so that is, I think, the value of us getting reports from across the city so that we can look at the large number of cases and potentially make comparisons to vaccine coverage in other groups.
We want to say thank you again to all of our presenters and to all of you who logged in to join us today and who stuck with us for this extra half hour. We hope that this information was helpful to you. Again, you'll be able to find a recording of this webinar as well as copies of these slides on our provider page by early next week. You can also find slides and recordings for all our previous webinars there as well. It's that link at the top of the screen. And we will look forward to having you join us next week, Friday, 2 p.m. Thank you very much.